Hello everyone, this is Dr. Govind Rai Garg. In this video, the topic is metabolism. So in pharmacokinetics, we were studying A, D, M, E. We have covered A and D, that means absorption and distribution in previous videos. So this is related to metabolism. So what all I expect you to know after the video, what is the aim of metabolism? What are the different types of metabolic reactions, different type of enzymes, microsomal as well as non-microsomal enzymes, their inducers and inhibitors, and CYP enzymes. Okay, so these are the information we want. So starting with the lecture, in pharmacokinetics we know it is ADME study: absorption, distribution, metabolism, excretion. So what we have discussed so far is, after absorption the drug will come to blood, then it will be distributed to different parts of the body. It will reach the target place, produce the action, and that action we will discuss in pharmacodynamics. Now, after the action is done, we want to stop the action because no drug keep on working forever. So we want to stop the action. What is the general process of terminating the action of a drug known as? When action of a drug stops, what is that general process known as? No, that is not called metabolism. That is called as elimination. Elimination is termination of action of a drug. And we have two methods to terminate the action. One, the drug may be metabolized. If a drug is broken down, the action may stop. And second, if a drug is not in the body, obviously it cannot work. So we can remove the drug out of the body and terminate the action. So that method is called as excretion. So combined together, this metabolism and excretion is called elimination. Okay? So if you see, pharmacokinetics is ADME, and this metabolism plus excretion we can say is elimination. So now we can redefine pharmacokinetics as study of absorption, distribution, and elimination of drugs. Okay? The elimination include both metabolism and excretion. So read carefully, elimination and excretion are not same. Elimination is a broader term, it also include metabolism. Okay, so absorption, distribution, metabolism, excretion is pharmacokinetics. So here we will first discuss about metabolism, then we will go to excretion. Now metabolism, the right word in pharmacology for metabolism is biotransformation. The name says biologically we are transforming, means converting one substance into some other substance. So what happens with metabolism? So normally we will expect that a drug which is active, which is working, after metabolism it will become inactive. But this does not happen always, because there are some drugs which are active, like diazepam. We know diazepam, it is used to suppress the brain. Person is not able to sleep, we give diazepam, person sleeps. So the action of diazepam is CNS depressant. Okay, so diazepam depresses the brain. After some time it is metabolized and it is converted to a compound known as oxazepam. Oxazepam can still depress the brain. So that means diazepam is active. After metabolism, it forms oxazepam, which is also active. So this can happen that active drug can be converted to active metabolite. So active drug can become inactive, but active drug can be converted to active metabolite also. The third thing is also possible. That means the drug was inactive, but after metabolism, it start working. Inactive drug is converted to active metabolite, and such a drug is known as prodrug. So prodrug is a drug which is itself inactive and it is converted to active metabolite. So is a diazepam a prodrug? The answer is no. Diazepam is not a prodrug because it is itself active. Prodrug is the one which is inactive and is converted to active compound. Yeah? And the name prodrug has been taken from the normal substances in the body. We have many substances in the body where the name start with pro, like proinsulin, prothrombin, prorenin. All of them are inactive. But when they are metabolized, like proinsulin, after metabolism becomes insulin. Prorenin become renin. Prothrombin become thrombin. So when they are metabolized, they become active. Yeah? So similarly, prodrug is inactive, When it is metabolized, we remove the pro, it becomes the drug. That means it is active. So pro drug itself is inactive, it is converted to active metabolite. Okay, so you need to remember the names of some important pro drugs which are asked in the MCQs. Although there are plenty of pro drugs, we will keep on discussing along with the various chapters when those drugs come. But here we will try to summarize which are the important pro drugs for MCQs. So pro drugs you can remember from the mnemonic. All prefer doing MD in clinical subjects. So the mnemonic itself says all prefer doing MD in clinical subjects. Very few are fool like me who take non-clinical. So what is the mnemonic? A for AC inhibitors. AC inhibitors. AC inhibitors are the drugs whose name end with pril. So all the prils. Any drug whose name end with pril, but you need to remember the exceptions except captopril and lisinopril. Any other drug whose name end with pril is a prodrug. Captopril and lisinopril are not prodrugs. They are active. So sometimes the question is asked which is the active AC inhibitor. These are captopril and lisinopril. So you can remember from the mnemonic ACL, anterior cruciate ligament. So active AC inhibitors are captopril and lisinopril. All other prils are prodrugs. Okay. Then P for proton pump inhibitors. The drug used for peptic ulcer. The drugs whose name end with prazo, omeprazole, lansoprazole, pantoprazole, all of them are prodrugs. Second thing on the P, apart from prazole, is prednisone. Prednisone. Prednisone is converted to prednisolone. So prednisone is also a prodrug. Then D for dopa. Dopa means levodopa. So levodopa is a prodrug. Then M for methyl dopa, minoxidil, and 6-mercaptopurine. Methyl dopa, minoxidil are antihypertensive drugs. 6-mercaptopurine is anti-cancer drug. They are prodrugs. Then D for dipivefrin. Dipivefrin is prodrug of epinephrine. That means adrenaline. It is used in glaucoma. Then I means irinotecan. It is an anti-cancer drug. C for clopidogrel and carbimazole. Clopidogrel and carbimazole. Clopidogrel is antiplatelet. Carbimazole is used in hyperthyroidism. And S means sulfasalazine. Sulfasalazine. And one more drug here is Sulindac. Sulfasalazine is used in ulcerative colitis and Sulindac is NSAID. So these are the important prodrugs. So I will advise not to ratify these drugs here. First read all the pharmacology. When you are used to these drugs, listening about these drugs, reading about these drugs, then come back to this mnemonic and remember it. Okay, so prodrugs you can remember as all prefer doing MD in clinical subjects. Now coming back, we discussed that after metabolism, active drug can become inactive. Active drug can form active metabolite and inactive drug can become active. The question is why metabolism occurs? What is the aim of metabolism? Had I asked you this question 5 minutes back, you could have easily answered. Metabolism is to make a drug inactive. But now you cannot answer because many drugs are active even after metabolism. So that means I have confused you more. No. The aim of metabolism has nothing to do with activation or inactivation. It happens. But aim, why metabolism occurs? Aim of metabolism is to make a drug water soluble. Whether the drug is active or it is inactive, but it will definitely be water soluble after metabolism. So aim of metabolism is to make a drug water soluble or polar. Aim is not to make it inactive. Now, why we want to make it water soluble, we will discuss later. But here just remember, aim of metabolism to make it water soluble. Okay? Now, there are two type of metabolic reactions. In biochemistry, we study two type of metabolic reactions, which are, yes, catabolism and anabolism. Now, because we are reading the different subjects, so we will name them differently. The thing is same. So, catabolic reactions, we normally name them as phase 1 metabolic reactions, and anabolic, we name them as phase 2 metabolic reactions. So, phase 1 means something will be broken from the drug, and phase 2 means something will be attached to the drug. Okay. So, common catabolic reactions like oxidation, reduction, hydrolysis, cyclization, deamination. So all these are phase 1 reactions. So phase 1 reactions are catabolic reactions, oxidation and reduction like reactions. Whereas phase 2 are anabolic reactions. That means something is added to the drug. So actually nothing is new which is synthesized, although they can be known as synthetic reaction. But the right term for them is conjugation reactions. Conjugation reactions means we will conjugate something to the drug, means something is already present in the body, drug is already present in the body, we simply attach the two. Conjugation. So conjugation reaction is the right word for phase 2 reactions. And which substance we can conjugate? We can attach glucuronide group, we can attach glutathione group, we can attach glycine group, we can attach acetyl group, methyl group, or sulfate group. So whenever we attach something, it is phase 2. Whenever we break something, it is phase 1. So from the name itself, you can remember like glucuronide conjugation or glucuronidation, glutathione conjugation, acetyl conjugation or acetylation. So from the name, you can identify it as phase 2 reaction. Okay, so phase 1 are catabolic, phase 2 are anabolic. The important thing to remember, oxidation is most common phase 1 metabolic reaction, whereas glucuronide conjugation is most common phase 2 metabolic reaction. Okay, so what is happening is, this is the drug and this is any of the phase 2 substance. It may be glucuronide, acetyl, methyl, etc. So phase 2 reactions means we attach the two. Okay, this is phase 2 reaction, and when we attach the two, the drug become water soluble. Okay, so what was aim of metabolism? To make a drug water soluble, and that is done by which reaction? Phase 2 reaction. So my question is, then why phase 1 occurs? When everything is done by phase 2, then why phase 1 occurs? Okay. So you can understand in this form, like drug is a paper and we want to paste something on the paper. So for pasting, what we want? We want glue, we want gum. So if the drug is not sticky, we cannot paste. So phase 1 reaction act like a Fevicol, act like a gum. So they make the drug sticky. So when the drug is sticky, then we can attach phase 2. Right? In technical term, that sticky thing is functional group. So basically what happens when phase 1 reaction occurs, the drug is broken. So the functional group is exposed. And when that is exposed, when drug becomes sticky, so now we can attach phase 2. So phase 1 reaction, the purpose is to expose the functional group of a drug, and phase 2 reaction is to make it water soluble. And remember, after every phase 2 metabolic reaction, drug will be water soluble. It may be active, may be inactive, but it will be water soluble. Okay. Now the reactions which we have discussed, so many reactions, they will be carried out by enzymes in the body. So little bit about drug metabolizing enzymes. So the enzymes we can divide into two broad categories. They can be microsomal, they can be non-microsomal. So drug metabolizing enzymes may be microsomal or non-microsomal. The first question is, what do you mean by microsomal? What do you mean by non-microsomal enzymes? The answer is very simple. The enzyme which is inside the microsome is microsomal. The enzyme which is not inside the microsome is non-microsome. Very simple. But my question is, what is microsome? What is microsome? So if you see the cell, we have this cell. In this cell, we have nucleus, we have mitochondria, we have Golgi complex, we have lysosome, we have endoplasmic reticulum. So many organelles are present in this cell. Endoplasmic reticulum is also known as microsome. That means the enzymes which are present inside the endoplasmic reticulum, they are microsome. And the enzymes which are present anywhere else, whether they are in the nucleus or in the cytoplasm or mitochondria, lysosome, Golgi, anywhere else, they are called as non-microsomal. Clear? So the enzymes which are inside the microsome means endoplasmic reticulum are microsomal, and those which are present anywhere else, they are non-microsomal. Yeah? Now, third and the most important question is, what is so special in the endoplasmic reticulum that we divided the enzymes based on that? We could have classified the enzymes as nuclear and cytoplasmic, or we could have classified as mitochondrial, not mitochondrial, or we could have classified as lysosomal, non-lysosomal, but not. We did not pick any of them. We picked up only endoplasmic reticulum. So there must be something special. So what is special in the endoplasmic reticulum? Why we divide the enzymes into microsomal and non-microsomal? And that special thing is only microsomal enzymes can be induced or inhibited. Non-microsomal enzymes cannot be induced, they cannot be inhibited. Only microsomal enzymes can be induced or inhibited. Non-microsomal enzymes cannot be induced, they cannot be inhibited. Now, what do you mean by this induction or inhibition? So, we'll try to understand with the help of an example. We have a drug called as warfarin. We know it is an anticoagulant drug. And we have another drug called as heparin. This is also anticoagulant drug. The difference is warfarin is metabolized by microsomal enzyme and heparin is metabolized by non-microsomal enzyme. Now we will make lot of assumptions. We will assume lot of things. Suppose we require 100 molecules of warfarin to produce action, and we assume we require 100 molecules of heparin to produce action. So we give 100 molecule, action starts. But after some time, these are metabolized to become 50. Suppose they are metabolized to become 50 with the help of 50 enzymes. Enzymes will break them down. So hypothetically, we assume that in one day, 100 molecules will be metabolized to 50. Because 50 enzymes are working, we have intentionally taken 50 to make it easier. One enzyme break one molecule in one day. Okay? One enzyme break one molecule in one day. So in one day from 100, they become 50. The same thing we assume here, that they will be metabolized to 50 in one day with the help of 50 enzymes. Okay. So when they become 50, the action will stop. We know we require 100 to produce the action. So what we will do? We will give 50 more. So when we give 50 more, they become 100. Again the action comes. Here also we do the same thing. We give 50 more, they produce the same action. So what we are doing, we are giving 100 molecules. After one day, they remain 50. So we give 50 more, they become 100. Again, they work, they become 50, they will become 100 when we give 50 more. So same thing for warfarin, same thing for heparin. Are you able to find out anything different between these two? We have kept everything same, but there is one thing different. What is difference? The difference is these enzymes are microsomal and these enzymes are non-microsomal. So whatever happens now will be due to these enzymes only. Okay. Now suppose this person who is taking warfarin, since 6 months, person is well controlled, taking warfarin daily, we give 50 molecules and it will become 100. So this is continuing since 6 months, no problem. Now this person developed tuberculosis, which is unrelated to warfarin. Nothing has to be done to warfarin. So person was taking warfarin, person developed TB, and to treat the tuberculosis, we start another drug called as rifampicin. Now rifampicin, it is a powerful enzyme inducer. Now what do you mean by inducer? Rifampicin increase the number of microsomal enzymes. So person was taking warfarin, we give him a rifampicin. So rifampicin went to these enzymes and said to them that you are not working enough. you need to work faster. So enzyme think that it is saying right. So the number of enzymes increase. So after giving rifampicin from 50, the enzyme number become 90. So when the enzymes are 90, they will break 90 molecules in same time. So that means in one day, now they break 90 molecules and only 10 will remain. If we do not think such thing is happening in the body, we will continue same dose. What dose we were giving earlier? 50 molecules. So if we give 50 molecules now, 10 plus 50 will be only 60. But we want 100. So the action will stop. So when we give enzyme inducer, it will induce the microsomal enzymes, increase the number of microsomal enzymes, that will increase the metabolism, so the drug will become ineffective. Okay. If we do not want this thing, we want that the drug should keep working, what we will do? Instead of giving 50, we now need to give 90 molecules. So what we will do is we increase the dose of a drug. Okay. So in enzyme induction, everything is increase. Enzyme inducer will increase the number of microsomal enzyme. That will increase the metabolism of the drug. So we increase the dose of the drug. Okay. So that is important about enzyme inducer. But on the other hand, if we give rifampicin with heparin, what will happen? Rifampicin will come to these enzymes and will say that you are not working properly, work more. So these enzymes will say that we know what to do, we don't want to listen. So they do not listen to rifampicin. That means these cannot be induced. So when they cannot be induced, their number will remain 50. So we do not need to change the dose of a drug. Okay? So that is the difference between microsomal and non-microsomal enzyme. A microsomal enzyme can be induced. So we need to adjust the dose of another drug according to that. Whereas non-microsomal enzyme cannot be induced, so we do not need to adjust the dose. Okay. Similarly, if we talk about enzyme inhibitor, so this we discussed as early, warfarin, 100 molecules were given, then they become 50, and every day we are giving 50 more. So person was controlled since 6 months. Now this person developed some acidity, and we start giving cimetidine to this person. Cimetidine is an example of enzyme inhibitor. So when we give cimetidine came to these enzymes and said them, you are working too much, please rest, otherwise you will get tired. And the enzyme think that she is saying right. So out of the 50 enzyme, 40 enzymes start resting, 40 enzymes are inhibited. So now only 10 are working. So when only 10 are working, they can break only 10 molecules. So what will remain? So now 90 molecules will remain. Out of 40 are resting, only 10 are working. So when only 10 are working, they will break only 10 molecules. So 90 will remain. And if we do not know such thing is happening in the body, we will continue dose as earlier. But dose we were giving 50 molecules. So if we give 50 now, what will happen? The total will become 140, nearly 1.5 times of what we require. So that can lead to toxicity. So obviously we will not want toxicity. So what we will do? We will reduce the dose. So instead of giving 50, now we will give only 10 molecules to make it 100. Okay. So important about enzyme inhibitor is enzyme inhibitor will inhibit the working enzymes, microsomal enzymes. So that will decrease the metabolism. So we decrease the dose because we do not want toxicity. Okay. Now if we give cimetidine with heparin, what will happen? It will come to these enzymes and say them, you will tire. They say, we know what to do, what not to do. We will not listen to you. So when they do not listen, means they cannot be inhibited. So the metabolism do not change. So we do not need to adjust the dose. Okay. So that is the main difference between microsomal and non-microsomal enzymes. A microsomal enzyme can be induced and inhibited, whereas non-microsomal enzymes cannot be induced. They cannot be inhibited. Okay. So now we will need to discuss little bit about these inducers and inhibitors. So important enzyme inducers are, they are remembered as GPRS cell phone. So when we get a cell phone with GPRS, our expenditure start increasing. So you can assume the enzymes also start increasing. So these are the drugs which increase the enzymes or induce the enzymes. G stand for griseofulvin. P is phenytoin. R is rifampicin. S is smoking. C is carbamazepine. And phone is phenobarbital. So the important enzyme inducers are griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, and phenobarbital. Griseofulvin is an antifungal drug. Phenytoin is anti-epileptic drug. Rifampicin is used in TB. Smoking we all know. Then carbamazepine and phenobarbital are also used in epilepsy. These are important enzyme inducers. If we write about enzyme inhibitors also here, so they can be remembered as vitamin K can cause enzyme inhibition. Vitamin K can cause enzyme inhibition. V stand for valproate, K for ketoconazole, C for cimetidine, second C for ciprofloxacin, E for erythromycin, and INH stand for isoniazid. These are the important enzyme inhibitors. So valproate is anti-epileptic drug, ketoconazole is antifungal drug, cimetidine is used in peptic ulcer, ciprofloxacin, erythromycin, and isoniazid all are antimicrobials. Now you can remember them as vitamin K can cause enzyme inhibition, but very important to remember, vitamin K do not cause enzyme inhibition. Do not mark that. Okay, so it is rather better to remember vitamin K cannot cause enzyme inhibition. That will be easier to remember. So these are important enzyme inhibitors. Now if you see carefully, you will note that most of the anti-epileptic drugs like phenobarbital, carbamazepine, phenytoin, they are enzyme inducers. But valproate is an anti-epileptic but enzyme inhibitor. So usually the MCQs are asked on exceptions. Most enzyme inducers, anti-epileptics are enzyme inducers, but valproate is inhibitor. Similarly, if you note that most of the antibiotics like ketoconazole, ciprofloxacin, erythromycin, isoniazid, they are inhibitors. Most antimicrobials are enzyme inhibitors. But griseofulvin and rifampicin, they are enzyme inducers. Okay? So exceptions are important to remember. Further, you can note that smoking, we discuss smoking is an enzyme inducer. The question which is asked, which substance in smoking is enzyme inducer? Which substance in the smoke is enzyme inducer? Very good. The answer is not nicotine. Nicotine is not the answer. It is not an enzyme inducer. The polycyclic aromatic hydrocarbons which are present in the smoke, they are enzyme inducers. The substance which are carcinogenic, which are causing cancer, in fact they will metabolize the substances to make them carcinogenic. They will metabolize pro-oncogene to oncogenes that lead to cancers. So smoking is enzyme inducer, but nicotine is not. That is important to remember. Okay? So now we can understand the clinical importance. Like we can take an example. There is a drug called as theophylline. Theophylline, it is used for treatment of bronchial asthma. It is metabolized by microsomal enzymes. So if a person is a smoker and we give theophylline, it will not work because the smoker will already have more enzymes. When we give theophylline, they will be metabolized. So the normal dose of theophylline will be ineffective in a smoker. So smokers require high dose of theophylline as compared to non-smokers. Clear? Second thing, a person is taking theophylline. Person is having bronchial asthma, person is on theophylline. And we know patient of asthma commonly develop respiratory tract infection. So this person goes to the hospital with respiratory tract infection and we give him ciprofloxacin or erythromycin. These are drugs used to treat respiratory tract infection. So if we give ciprofloxacin or erythromycin with theophylline, what will happen? They will inhibit the metabolism of theophylline. And when theophylline metabolism is inhibited, its plasma concentration increase. So that can lead to toxicity, like there can be seizures, there can be arrhythmias. At overdose, theophylline stimulate heart and brain. So there will be tachycardia, there will be arrhythmias, there will be seizures. So it is important that we should not give enzyme inhibiting drugs like ciprofloxacin or erythromycin with theophylline. So this is important about the enzyme inducers and enzyme inhibitors. Okay. Now we need to discuss one thing very important about a group of enzymes known as cytochrome P450 enzymes. Now cytochrome P450, it is one type of microsomal enzymes. What I want you to remember is we have two main type of enzymes. Some are in the endoplasmic reticulum, they are called microsomal. Some are outside them anywhere else, they are called as non-microsomal. Now there are many microsomal enzymes. These are not the only microsomal enzymes. Most of the phase 1 reactions are done by microsomal enzymes, but most phase 2 reactions are done by non-microsomal enzymes. But in phase 2 only one enzyme is microsomal, that is glucuronide transferase. Glucuronide transferase, this is also present in the endoplasmic reticulum. So only phase 2 reaction which is carried out by microsomal enzymes is glucuronide conjugation. But be very careful, cytochrome P450 and glucuronide transferase are different enzymes. Both are microsomal. Okay? So CYP are one of the microsomal enzymes, glucuronide is another microsomal enzyme. Okay, so here we will be concentrating on CYP or cytochrome P450 enzymes. First of all, coming to nomenclature, what do you mean by P in the cytochrome P450? So P stand for pigment. So these are the enzymes which contain a pigment which has maximum light absorption at a wavelength of 450 nanometer. Okay. Now they are given nomenclature. Their names start with CYP. So after CYP, there will be a number 1, 2, 3, anything there will be a number. And after the number, there will be a letter A, B, C, something like that. And after the letter, there will be another number 1, 2, 3, 4, like that. So what is this nomenclature? So first thing, first number which is there, that is known as family. So CYP consists of many families. CYP 1, 2, 3, 4 and so many. Yeah. Now every family has many subfamilies which are represented by letters. So the letter is representing these subfamily. So we have CYP 3A, 3B, 3C and so on. Now every subfamily will have some isoforms, so that is represented by another number. Okay. So CYP 3A4 means it is of third family, 3A subfamily and 3A4 is the isoform. Okay. So now you need to remember the important substrates of CYPs. But before that, two CYPs, CYP3A4 and CYP2D6, these metabolize most of the drugs. Around 50% of the drugs are metabolized by 3A4 and another 20% around is metabolized by 2D6. That means these two enzymes are the most important microsomal enzymes involved in drug metabolism. Okay, so we will discuss some of the important drugs metabolized by important CYP enzymes. So starting with CYP3A4. The drugs which are metabolized by CYP3A4, we discussed around 50% are metabolized. So plenty of drugs are there, but you need to remember which are important for MCQs. And these drugs you can remember as CT scan. The drugs metabolized by CYP3A4 are remembered as CT scan. C for cyclosporin and T for tacrolimus. Both of them are immunosuppressant drugs. They are metabolized by CYP3A4. Then S for statins. So hypolipidemic drugs like atorvastatin, simvastatin, these are metabolized by CYP3A4. Then on the C we have a group of drugs called as CAT drugs. CAT drugs stand for three drugs: cisapride, C for cisapride, A for estamizole, and T for terfenadine. So CAT drugs, cisapride, estamizole, and terfenadine, they are metabolized by CYP3A4. Now, what is important about these drugs is all the three drugs, they have been banned. They have been withdrawn around 15 years back. But still, examiner asks MCQs about them, why they are banned. The reason why they were withdrawn were at high concentrations, they can result in an arrhythmia known as torsades de pointes. Torsades de pointes is an arrhythmia caused by these drugs, and in ECG this arrhythmia presents as QT prolongation. So these are the drugs which cause QT prolongation in overdose, and that's why they were withdrawn from the market. Okay, so you can remember this as, we know cat is cute. So QT means cute. So cat is cute. So cat drugs are cute. That means they can cause QT prolongation. Okay. Then A stand for amiodarone, and N stand for navirs. So any drug whose name end with navir, like ritonavir, emprinavir, lopinavir. So navirs are drugs which are used in HIV. They are used as protease inhibitors in the treatment of HIV. Clear? So these are the important drugs which are metabolized by CYP3A4, remembered as CT scan. Okay, cyclosporin, tacrolimus, statins, CAT drugs, amiodarone, and navirs. Okay. Then moving to the second important, it is 2D6. And 2D6 is easy to remember. You can remember we have 2, we have D, and we have 6. 2. 2 means second. First is alpha, second is beta. So 2 means beta, beta means beta blockers. So beta blockers are metabolized by 2D6. Then D means depression. So the drugs which are used for treatment of depression. Most of the antidepressant drugs like tricyclic antidepressants, SSRI, SNRI. So these are metabolized by 2D6. Most of the TCA, SSRI, SNRI are metabolized by 2D6. We will discuss about them in detail when we will discuss CNS. Okay? And third is 6. If you say 6, it look like we are talking about sex. So when we talk about sex, our heartbeat increases. So to control that heartbeat, the drugs used are anti-arrhythmic drugs. So most anti-arrhythmic drugs are metabolized by 2D6. But here you need to remember one very important exception which we already discussed. Yes, it is amiodarone. Amiodarone, it is metabolized by 3A4. Remember, CT scan, A for amiodarone. So 2D6 other anti-arrhythmic drugs. Okay. Now, apart from these, we have another enzyme called as 2C19. 2C19. If you see 2C19, you can see C1 look like Cl. So this is an enzyme which is involved in metabolism of clopidogrel. Cl, clopidogrel. Now, what is special to remember? Clopidogrel is an antiplatelet drug, but it is a prodrug, means it is inactive. So it need to be metabolized to become active. So for antiplatelet action, it need to be metabolized, and the enzyme which metabolize it is CYP2C19. Now some people, they have genetically deficient CYP2C19. Some people have less number of CYP2C19. So clopidogrel is less likely to work in these patients because it is not active. Another important thing, there are some drugs called as prazoles, proton pump inhibitors like omeprazole, lansoprazole. They can inhibit CYP2C19. So when we give clopidogrel with omeprazole, it will inhibit its activation. And when it is not activated, it cannot work. So we should avoid this combination. So among the PPIs, most of them inhibit CYP2C19. The least inhibition of CYP2C19 is by pantoprazole and rabeprazole. Most other prazoles, they inhibit CYP2C19. Okay, so that is 2C19. Then lastly, we have CYP2C9. And from the 9, you can remember, if you see 9 in the mirror image of 9 look like P. So you can remember that as phenytoin is the drug which is metabolized by CYP2C9. Clear? So these are the important drugs and which are metabolized by different CYP enzymes. Okay, so we can quickly discuss what are the important points you should know from this video. Yeah. So you should know that metabolism plus excretion is called as elimination. Then the major aim of metabolism is to make a drug water soluble. You should know important prodrugs. We discussed the mnemonics of the prodrugs. Then you should know you should know is difference between microsomal and non-microsomal enzymes. What is the clinical difference? Then important enzyme inducers and inhibitors that we discussed. And lastly, the important drugs metabolized by CYP enzymes. That is the basic thing you should know. Yeah. So quickly we can discuss some questions. The most important one question which was asked on this is, a patient with a stroke was started on clopidogrel. He developed another episode of stroke 6 months later. Means clopidogrel was not able to prevent. Which of the following is likely cause? So rapid metabolism by 1A2. Clopidogrel is metabolized by which enzyme first? So see, it is Cl. So remember, it is C1, that means C19. Clear? So it is metabolized by CYP2C19, but read the option poor metabolism by 2C19. Yes, if there are lesser number of CYP2C19 enzyme, it cannot be metabolized enough, so it will not become active, so it will not be able to prevent. So that is the right answer. Clear? So my suggestion to you, and which I always say to everyone, is never give up. Okay? So you are so close to the victory. So do not dare to give up now. Okay? So always be positive. Thank you.